Welcome to Oncology Watch. I'm Liz May with Rocky Mountain Cancer Centers. Today, Dr. Lori Jensen, medical oncologist with Rocky Mountain Cancer Centers, will be providing you with some insights on understanding your breast cancer pathology report. Dr. Jensen practices at our Boulder Clinic and has been with our group since 1995. Dr. Jensen is chair of the Breast Cancer Committee at Boulder Community Hospital and actively participates in clinical trials for breast cancer. Now I'm going to turn it over to Dr. Jensen.
Thank you, Liz. So as Liz stated, the topic that I wanted to go through today is understanding your pathology report. So the pathology report or reports are probably the most important bits of information or pieces of information that your doctors are using to ultimately make the most appropriate treatment recommendations for a specific type of breast cancer. It's very important that we, as the treating physicians, have a very clear understanding of the pathology report, because really our recommendations as the surgeon, the medical oncologist, the radiation oncologist, our treatment recommendations are really only as good as our understanding of the pathology report. And so it's often, these are often details or information that we're reviewing in great detail at our tumor boards, our weekly tumor boards, or sometimes even going down to the pathology department and looking at slides with the pathologist, so that we can be really certain that we understand the information that the pathologist is trying to relay. So with that said, I will get started here. So there's at least 3 different types of reports that get generated throughout a breast cancer diagnosis. There's the initial biopsy pathology report that's generated obviously after the initial biopsy, which most of the time is going to be a needle biopsy. There may be subsequent biopsies that follow. Sometimes there's just the one biopsy. Following all the biopsy pathology reports, then we get a surgical pathology report, which is obviously the report that's generated when a woman has either a lumpectomy or a mastectomy. And then the synoptic report is basically the kind of final report that puts everything together for us. And the synoptic report is typically kind of tacked on or at the end of the surgical pathology report. So before we get into details about the report itself, I wanted to just review some of the anatomy of the breast. So this is looking at the breast from a side view here. And oh, hang on a second. I'm wondering, oh, there's my cursor. There we go. So the yellow dots here are ribs on cross section. This here would be the pectoralis muscle. And then these yellow areas are fatty tissue in the breast. And the pink areas here represent lobular units in the breast. So here, these pink cells are make up the lobule, and this is where milk is essentially made, and then the milk comes down through this ductal system out the nipple. So this is my drawing of that anatomy, and I often use this picture when I'm talking with patients to try to get across some important concepts here. So again, here's the lobule lined with one cell layer normally. Milk is made in the lobule and comes down through the ductal system. So normally the ducts here should be lined with one cell layer, and if we take one of these ducts and cut it on cross section, so now we're kind of looking down the duct toward the nipple, a normal duct really should be one cell layer and with a hollow lumen. So what happens, for reasons we don't know why, in any given woman, one of those ductal cells, and I depicted that here as a black dot, one of those ductal cells becomes malignant. And what that means then is that one cell starts to grow and divide in an unregulated way. Oh, excuse me. So initially what happens is as the cancer cells are growing and dividing, initially they fill up the duct. And if we were to look at that on cross-section here, again, kind of cutting that area on cross-section, this is what we would see, basically cancer cells that are now filling up the lumen of the duct. And this is an early form of cancer called ductal carcinoma, so just cancer of the duct in situ. And the in situ just means that everything is contained within the duct. So the abbreviation for this, the terminology is DCIS. So then what can happen over time is those cancer cells that are in the duct can break out of the duct and start to invade or infiltrate into the fatty tissue of the breast. And if we were to look at that on cross-section, that would look something like this, where now the cells are coming out of the duct. The terminology you'll hear is either invasive or infiltrating, means the same thing. It's basically cancer of the duct that's invading or infiltrating into the fatty tissue. And here you can see we're starting to get something that's more like a lump or a nodule or something that we could actually put a measurement on or even possibly feel. And one of the reasons why we get concerned about invasive or infiltrating either ductal or lobular cancer is that what could happen, it certainly doesn't happen most of the time, but what could happen is cells could invade into one of the lymph vessels or one of the blood vessels that are in the fatty tissue of the breast, and cells could get taken out of the breast before we even know the cancer's there. So here's a depiction of a lymph vessel ultimately draining into the first lymph node that the first lymph node that the lymphatics from the breast drain into is called the sentinel lymph node. And most commonly that lymph node is in the armpit area, or the axilla, which is the medical term for the armpit. So here I've drawn the sentinel lymph node, which is the first lymph node the vessels are draining into, and then there's many other lymph nodes up in the axilla that are called non-sentinel lymph nodes. And then this is just a depiction here of a needle biopsy where the needle is going through normal breast tissue, but then ultimately into this abnormal nodular area there. So there's different types of tumor types of breast cancer. The most common type is invasive ductal carcinoma, which I just reviewed. Invasive lobular carcinoma, basically same thing, but it's just happening in the lobule. Ductal carcinomas in situ is where everything is contained in the duct. And then there's other less common types of breast cancer that I won't really go into. Excuse me, I have a touchy mouse here. Other less common types, such as mucinous, tubular, papillary, and other types. So on the initial biopsy pathology report, there's lots of really important information that we obtain. So first of all, is the tumor type? Is it an invasive ductal, invasive lobular, or ductal carcinoma in situ? We get information about what's the longest length of tumor that's in the sample. So that's not going to be the size of the tumor, but if you remember the needle going into the tumor, it's the length of tumor that comes up into that needle. We get information about the grade of the tumor, and this often will get confused with stage, which I'll talk about later, but grade really refers to kind of how abnormal do the cancer cells look. So if the cancer cells look very similar to normal ductal cells, we call that grade 1, and those tend to be slower growing cancers. Cancer cells that look very dissimilar and very different from normal ductal cells would be grade 3 cancers, and then obviously in between would be grade 2 cancers. Most cancers are grade 2, but depending on the pathologist, another form of terminology they may use as a grading system would be well, intermediate, or poorly differentiated, which is the same thing as grade 1, 2, or 3. We also typically get information about whether or not the pathologist is seeing lymphovascular space invasion. So what that means is, if you remember, those little lymph vessels and little blood vessels that are in the fatty tissue of the breast. The pathologist is able to tell us whether or not they're seeing any cancer cells in some of those small vessels in the biopsy specimen. So we get either a report of what we call LVI is either present, absent, or indeterminate. And then very importantly, we get really critical information about the receptors in the breast biopsy. So I'll go over these in a minute in more detail, but we're specifically looking at estrogen receptors, progesterone receptors, and what we call HER2 receptors. So, and then finally, we get information, something called the Ki-67 or MIB1 proliferative index, which basically just is a measurement of what percentage of cells are growing and dividing. So a low Ki-67 would be a slower growing cancer. A higher Ki-67 or higher MIB proliferative index would be a more aggressive or more rapidly growing cancer. So getting back to the estrogen receptors, I have a cartoon here that'll help, I think, with the explanation. So this large pink oval here, think of that as a breast cancer cell. And within the breast cancer cell is this green circle, which is being depicted here as what we call the estrogen receptor. So this is a protein that's inside the cell that, well, inside some breast cancer cells. Now, some breast cancers, maybe 20% of breast cancers don't have the estrogen receptor, but what we're trying to determine with these stains on the initial biopsy is, first of all, is it there or is it not there? And if it is there, kind of what's the extent of its expression? So the way that, what we're seeing on this diagram here is that estrogen that may be in the bloodstream is able to enter into this breast cancer cell, and if the receptor is there, it's able to bind to the receptor. And basically what it does is it kind of stimulates this cancer cell or turns it on. So this cancer cell then can start to grow and divide and proliferate. If the estrogen receptor isn't there, then estrogen's not going to have an effect on the cancer cell. And it's really important for us to know whether or not it's there or not as we're kind of thinking about treatment options, because trying to do anti-estrogen treatment in a situation where the estrogen receptor isn't present isn't going to be helpful. I think also another important kind of concept that this diagram is showing is it's not that estrogen is causing the breast cancer cell, but if the cancer cell is there and it has the estrogen receptor, it's kind of turning it on or stimulating it. This is a little fuzzy, but kind of a similar concept with the HER2 receptor. So on the left is a cancer cell again, and instead of these receptors being inside the cell like the estrogen receptors, these receptors are on the surface of the cell. And HER2 is a protein, a normal protein that's in many cells in our body. And normally what the protein does is it tells cells to grow and divide, which is a normal process if it's a regulated growth and division. But some cancers are going to have too many of these HER2 receptors on the surface. And we would call those HER2 positive cancers. And those cancers are more aggressive, and they're growing and dividing at a more rapid rate. So let me go back to this previous slide and just kind of go over again the estrogen receptor. Basically, the pathologist is putting a stain on the slide that is going to bind to the receptor if it's there. So we'll get a positive or negative result on the estrogen receptor, but we'll also get information about it being strongly positive or weakly positive, or what percentage cells are positive, or we'll get the information that it's negative. Same thing with the progesterone receptor. It's positive or negative, and we get a certain degree of positivity on it. Progesterone receptor is actually much less important, and we really focus most of the treatment recommendations are really coming from the status of the estrogen receptor. The estrogen and progesterone receptor stains are typically done in the lab that is processing the initial biopsy, and so we usually get those stain results back like within 2 days. The HER2 stains are really best done in high volume labs, and so different hospitals will use different reference labs to test the HER2. Here at Boulder Community Hospital, we use Mayo as our reference lab. So basically, the biopsy is done, the tissue is processed, the next day the tissue is FedExed to Mayo, and we'll get either a negative result back, which is reported as 0 or 1+, or we'll get a positive result, which means there's excess HER2 receptors on the surface of the cancer cells, and that would be reported as a 3+. Or we'll get something called equivocal or indeterminate, which is 2+. And these indeterminate or equivocal results require further testing by something called FISH, fluorescent in situ hybridization, but we have to do further testing to sort out, are these 2+ results either positive or negative? So just from a practical standpoint, we're getting the estrogen and progesterone receptors quickly within the first 2 days. The HER2 results are going to be a little delayed because they're send-out tests, but if it's clearly negative or positive, we get those results, maybe within 4 or 5 days. But if it's one of these equivocal 2+ results, it may still take another 2 weeks sometimes to get the final FISH result. So sometimes it takes a little longer to get the full initial biopsy path report information. So this is just an example from one of my patients. This is her biopsy pathology report. And so initially, going through the report here, initially the first specimen, they did needle biopsies of a mass on the left in the 12 o'clock position, so the upper aspect of the breast. That came back a fibroadenoma, so that was benign. But then the next biopsy they did was of a mass in the 11 o'clock position. And this biopsy here then showed an infiltrating ductal carcinoma. It was 8 millimeters in the sample, meaning 8 millimeters of tumor went up into the needle there. This tumor was grade 2 out of 3. The pathologist did not see definite lymphovascular space invasion. There was some ductal carcinoma in situ present, the cancer that's in the duct. The estrogen receptors were kind of moderately positive, so half of the cells, half the breast cancer cells stained. The progesterone receptor was strongly positive, 90% of the cells were staining. The HER2 receptor got sent out to Mayo, so they're basically saying, we'll let you know what the result is when that's back. And then this mid-proliferative index on her was a relatively lower number at 3%. And then a week or two later, we got the HER2 results. Initially, the HER2 result was reported as equivocal, which was 2+. And then again, a week or two later, we got what we call the HER2 FISH. It's kind of a silly name. FISH result back, and it was positive. So initially, we gained very important information about kind of how we're going to think about this cancer from a treatment standpoint. And I just listed here some of the terminology that is often used, and I'm not sure we explain it very well all the time. But cancers at this point, we'll be calling them ER positive, which is estrogen receptor positive, ER positive, HER2 negative, or ER positive, HER2 positive, or if a cancer is estrogen receptor negative, progesterone receptor negative, and HER2 negative, that's the terminology we may use there is triple negative. It doesn't mean that the cancer is triply bad. It just means that all 3 of these receptors are staining negative. So after all the biopsies have been done, now we're going to move on to surgery, and it may be a lumpectomy or it may be a mastectomy. And there's additional information that we are able to glean from the surgical pathology report. So again, the pathologist is going to tell us the tumor type. It should be the same as the biopsy. Sometimes we get more tissue and it might be a little different, but it'll either be an invasive ductal or lobular or DCIS or one of the more less common types. We'll get really definitive information about the size of the tumor, because now we have the whole tumor rather than just a sample with the needle going into the tumor. We get very important information about the margins. And I'll go over that a little bit more here in a minute, but basically we want to know that the surgeon was able to get around the cancer and that there's some normal tissue between the tumor and the edge of the tissue that was removed. And then it's also at the surgical, it's also at the time of surgery that we now get information about the status of the lymph nodes. And the lymph nodes are going to be labeled by the pathologist as either the sentinel lymph node, which again is the first lymph node that the lymphatics in the breast drain to, or sometimes other lymph nodes are sampled and they're called the non-sentinel lymph nodes. So this is just a cartoon or a diagram of what we mean by margins. And this, in this situation, you can kind of think of it, this would be kind of more of a lumpectomy situation where we're looking at the margins. And this is obviously 2-dimensional. Normally, you know, obviously a lumpectomy is going to be 3-dimensional. But in this diagram here, this is the lumpectomy specimen, and the pink area would be normal breast tissue, and the central area is tumor. And here the margins are negative. And there's a dimension or a measurement that the pathologist can tell us about the extent of the margin. In this situation, the margin is positive. The cancer cells are going right up to the edge of the lumpectomy. And the issue there is we don't know, are there cancer cells on, did the surgeon get right on the edge of the tumor, or potentially are there more cancer cells on the other side of the lumpectomy cavity? When we're talking about lumpectomy margins, there's basically 6 of them. There's the upper margin, which is called the superior margin. There's the lower margin, which is the inferior margin. Anterior margin, which is the margin closest to the skin. Posterior margin is the margin closest to the pectoralis muscle. And then lateral margin, which is off to the side, and medial margin, which is more toward the middle. So we get all 6 of those margins typically reported in a lumpectomy specimen. If a woman's having a mastectomy, really the main margins that we're looking at now are going to be the posterior margin, meaning the margin that goes right up to the muscle. We want to make sure that there's not tumor cells that are going right up to the pectoralis muscle. We want to make sure that the surgeon gets around that deeper margin. And then we also get told on the pathology report, or get information about the anterior margin. So here the breast tissue is being removed just right underneath the skin, and that we would call that the anterior margin. So, so typically lumpectomy specimens have the 6 margins that are looked at, and for a mastectomy, it's typically the posterior and the anterior margin. And again, this is the same patient. This is her lumpectomy pathology report. And so here, the surgeon or the pathologist identified that the surgeon took out a sentinel lymph node on the left. 1 lymph node was removed, was negative for cancer. And then the left breast lumpectomy specimen was identified. And in that lumpectomy specimen, there was invasive ductal cancer. It measured 1.2 centimeters. They graded again, so it's grade 2. There was some DCIS present. And then here's a comment about the margins, that initially, on the initial lumpectomy specimen, the invasive cancer was at the superior margin. There was cancer that was at the superior edge of the lumpectomy, and it was 2 millimeters from, I think that's the medial margin. It got cut off there. And negative, but very close, less than 1 millimeter from the inferior margin. And then all these other margins were greater than 5 millimeters. Initially here, DCIS was close to these other margins, less than 1 millimeter. And then what the surgeon did, though, is they took out additional tissue on the upper part, the superior part, the medial part, which is more the middle part, the inferior, lower, lateral, and then posterior. And so what we're able to determine from this additional information is that even though initially the superior margin, the upper margin, was positive and the inferior margin was really close, we see here that the surgeon took additional tissue from the upper aspect and there was no cancer in it, and additional tissue from the inferior aspect and again no cancer. And here on the lateral there was a little bit of additional cancer, but the final margin, here it says invasive ductal cancer is present 6 millimeters from the final inked margin. So basically this is a negative margin. So here we have the lymph node. One lymph node is sampled, it's negative. The cancer is 1.2 centimeters. It's grade 2. Initially, there were some margins that were either close or positive, but now we can see that the margins were all finally cleared and are finally negative. So the synoptic report, so we've done the biopsy report, we've done the surgical report. The synoptic report is basically included on the final surgical report. And basically the way to think of the synoptic report is that it's kind of putting everything together. It's putting the size of the tumor, the lymph nodes, the receptors, the margins. So again, specimen features, are we talking right or left? Is it lumpectomy or mastectomy? The lymph nodes. Again, the tumor characteristics, the type of cancer, the size, the grade, the lymphovascular space invasion, margins, lymph nodes, and then the markers are put in that report as well. And very importantly, kind of the last bit of information that is on the synoptic report that we haven't had yet on the biopsy or surgical report is the anatomic stage. The stage of the cancer, which means basically the extent of the cancer. So this is her synoptic report, and a lot of this is redundant, but it's a left lumpectomy with a sentinel node sampling, the tumor characteristics, invasive ductal, 1.2 centimeters, grade 2, DCIS was present, there was not this lymphovascular space invasion. Final margins are uninvolved for both invasive cancer and DCIS. Number of lymph nodes sampled were 1. The number of lymph nodes that had cancer in it was 0. And now we're pulling in the receptor information from the biopsy pathology report. The tumor is ER/PR positive and HER2 was positive by FISH. And then this is the additional information that we get on the synoptic report, which is the pathologic staging. And I'll go through that here in a minute, but this cancer was staged as what we call a T1C N0. So when we're staging breast cancer, we use what we call the TNM system. T stands for tumor size, N stands for the number of lymph nodes involved, and then M stands for whether or not there's any distant metastasis. So did the cancer go to the bone or the lung or the liver? So any metastasis outside of the breast and the regional lymph nodes. So this is getting a little complicated, but let me just try to do an overview for you here. So so for the T aspect of this, TIS basically stands for If the cancer is DCIS or ductal carcinoma in situ, where it's all contained in the ducts, that would be TIS. T1 cancers are basically cancers that are under 2 centimeters, and they get broken down to T1A cancers, T1B, or T1C based on the size. Most breast cancers actually are probably T1C cancers, meaning that they're between 1 and 2 centimeters. T2 cancers are between 2 and 5 centimeters. T3 cancers are greater than 5 centimeters. And T4 cancers are cancers that are either involving the skin or the chest wall, or a type of cancer called inflammatory breast cancer. So the N part of the T&M staging refers to lymph node involvement. So N0 would be no lymph node involvement. N1 would be 1 to 3 lymph nodes involved. N2 would be 4 to 9 lymph nodes involved, and N3 would be more than 10 lymph nodes involved, or lymph nodes in other areas than just the axilla or the armpit. And there's lots of different breakdowns of these various nodal stages, but this is, again, just kind of an overview. And then M is either going to be M0, which is no known metastases, or M1, that we are able to see that the cancer is spread outside the breast and the regional lymph nodes to other organs. So basically the T's and the N's and the M's get combined to create a final stage. And this gets very detailed, but again, broad overview. Stage 1 cancers, the way to think about stage 1 cancers is they're under 2 centimeters and lymph node negative. So they're either going to be T1A, T1B, or T1C, N0. Stage 2 cancers are typically cancers that are going to be a little larger, so between 2 and 5 centimeters, or cancer of any size, or possibly a smaller cancer that has some lymph node involvement. That would be stage 2 cancer. Stage 3 cancers are going to be larger or maybe more lymph node involvement. And then stage 4 cancers are when the cancers do have that M1, that metastasis. So basically what that path report that we just looked at, it gave us the anatomic stage, which was stage 1. It was T1C because it was 1.2 centimeters, and 0 lymph node negative. So anatomic stage basically is based on the size of the tumor and the lymph nodes. What we're recognizing more and more is that it's really not all about the size of the tumor and whether or not the lymph nodes are involved, and that there's definitely additional information that we need to, that is very helpful in terms of ultimately deciding how best to treat a cancer. It's not only the lymph node status and the size of the cancer, but also the biology of the cancer. How aggressive or not aggressive is the cancer? And that type of a staging system, it's a newer staging system that we're using. It's called the Prognostic Staging system. This is not yet always incorporated yet on the synoptic reports, but clinically, we as physicians are using this more and more. And basically what the prognostic stage is telling us, it combines the anatomic stage, so the size and the lymph node involvement, but gives additional information about the biology of the tumor, taking into account estrogen receptors, progesterone receptors, HER2 status, and the grade of the tumor. So you can imagine all the various ways that you can combine size, lymph nodes, ER, PR, HER2 new, grade. I mean, there's, probably hundreds of combinations there. We have, computer programs now that can give us where we can actually calculate out the prognostic stage. But the idea here is that you can have smaller tumors, stage 1 cancers, that are more aggressive. So maybe even though it's a stage 1 cancer, if it's estrogen and receptor negative and HER2 negative, that may be a more aggressive cancer than a larger cancer, maybe even with lymph node involvement, if it's a really slow growing cancer. Estrogen receptor positive, grade 1, low Ki67. So this prognostic staging, we're using it more and more, and it's really gives us much more information about how this cancer is going to act, in addition to just the size and the lymph node status. So that is a flyover overview of Pathology 101. That's the end of my presentation, and I just appreciate the opportunity to review this with you, and I hope it's helpful. Thank you.
Thank you, Dr. Jensen, for presenting this information to us, and thank you to all of you for watching today. If you have any questions, we encourage you to talk to your medical oncologist or to call any of our Rocky Mountain Cancer Center sites. Thank you so much.
Thank you.